Welcome everyone. Welcome to Ask the Mentor. It's Tuesday night at 7 and you know where I'm going to be. For those of you who are expecting Nurse Amy Burks tonight, she was supposed to be sharing this with me. We're going to have a nursing takeover, so to speak, but a little while ago she direct messaged me and said that her daughter has a concussion and we're not going to be able to have her on tonight, and that's okay. You know, we can pivot. She's going to be on October 26th. And we'll be talking about education, like the level of aesthetic education in this country and what we're doing to improve it. She's a founder of a company called Glow Derma, and she kind of does what I do, and I wanted to just compare notes with her, and I thought it would be a good idea. Nurse Preddy, hello, who just joined. She's going to be doing a live with me Thursday night, so she's probably looking in. How are you? Good to see you again. Marjorie is one of our amazing nurses that went through our school, and she's done a great job, and she's on her own, and I'd like her to talk to you guys about what her journey's been like and where she is now. So thank you. Austin Inmode, as always, right on top of your game. Heather Vanderbilt, one of the other NPs who's taken over the show, thank you for joining. Someone sent me a request to be in our video, to be on our live. This person above, yeah. Hello, Heather. Thank you for joining us. We were going to have Amy Burks, RN, on tonight, but her daughter has a concussion, so she's joining us on the 26th. And Marjorie Preddy's going to be here on Thursday night. A rare Thursday appearance for the Mentor. A very rare but special appearance, so I'm happy to be here. Where are you guys from? Is anyone from far away? Anyone joining us from, let's say, Europe or the Canary Islands or Argentina or maybe even Peru? Or your hometown, which is Brazil.
Yeah, it's Brazil. Country, yeah. It's São Paulo.
São Paulo. So anyway, tonight's going to be a little different. We got a couple interesting things to talk about. I want to talk to you about my cadaver class that I did yesterday. I drove down to Connecticut. Hey, Austin, we got some business coming your way soon. Glad we were able to work something out. Danny wants to be in our video.
Nice.
I don't know who that is, but
we'll
try it. Should we try it? Okay. So anyway, I drove down to Connecticut yesterday. I got up at like 6 in the morning, drove down, left the house around 6:45, came back last night around 7 p.m. So it was a long day, but it was a really fun day, and I learned a lot from the students. I wanted to share some of your things because in the last installment of Instagram, the Ask the Mentor last Tuesday, we talked about occlusions. We had a lot of interest, and I talked about blindness. You know, I talked about what happens with blindness, and I thought to myself, actually Heather, who's on this call, asked Dr. Yolen a lot of questions about occlusions, but she was really, I don't want to say rattled, Heather, because you're never rattled. You're like rock solid, stable, tough as nails. But she said, you know, 2 years ago, you came in and, hey, Green Rise Homes, they're the people to go to if you ever need a home. These guys are amazing home builders, and Green Rise Homes, love these guys. Hello from Boston, Jola. I don't know if it's Hola or Jola. So anyway, we were talking about it. Heather was like, oh my God, I'm so, you know, I still remember 2 years ago the talk you gave about blindness and retrobulbar injections of hyaluronidase. And she's like, I could actually almost, you know, recite verbatim to you, Dr. Yolen, what you were saying. So we launched into a discussion about that. And I thought to myself, you know what? If you ever have a situation where someone is blinded, and I want to sort of preface this by also saying that Dr. Yolen revealed that there were 3 very, very prominent doctors, you know, that pretty much everybody who's on this call, on this Ask the Mentor would recognize. A famous plastic surgeon, a famous facial plastic surgeon, ENT docs, whatever you want to call them, and a dermatologist, that's a household name. All 3 of them blinded patients in the past year or so, you know. And it was kind of startling in a way, but understandable to me as we have done more and more anatomy dissections. And I thought to myself, you know, as I was explaining this to the students, you know, why is an occlusion, you know, of the central retinal artery or the ophthalmic artery, which obviously includes the central retinal artery because that's downstream, why is that so different than, you know, someone who's doing a lip or a cheek or a chin or wherever and they get an occlusion? Because we know those are manageable. Hello everyone, tell me where you guys are from. I like to see people calling from far away or even from close. It's just really interesting to see what our audience looks like. So thank you all for joining. And let me know if you're an NP, MD, RN, PA, what your interest is, and if you have any questions, feel free to ask. But so we thought about it. So like, why do you have to act so fast in the case of blindness as opposed to any other type of occlusion anywhere else on the face, or really anywhere else in the body for that matter? And of course, the answer is that the retina is an extension of the brain, right? So how long can your brain be hypoxic or anoxic before you start having irreversible damage? And I don't know. It's certainly, not much more than 10 or 15 minutes, right? And then you're pretty much done. So blindness is the same way. If you, hello, Hanover, Massachusetts. So if you do have that, patient that's got blindness or complaining of difficulty seeing right after you've injected them, you really don't have time. You really don't have time to do anything except treat the patient. It's sort of like if someone, kind of drops dead in front of you and they have an arrest, a cardiac arrest. You can't like say, well, what should I do? And should I call someone? Should I look around for? You start CPR because the patient's dead, and if you don't fix them, they stay dead, right? Same thing happens with blindness. If you have a central retinal artery occlusion and the patient retina is not getting any blood, then you've got maybe 15 minutes. So what can you do in 15 minutes? Nothing. You have to get the hyaluronidase into that retrobulbar space. So we thought what we would do is have the students all do retrobulbar injections. So we started the cadaver class by talking about what I'm talking about right now, and everyone was like, what do I do? How do I do it? So we just showed that we actually dissected the eye out of the socket first. We actually took the eye out, and we're holding the eye in our hands. We're kind of passing it around. We gave the students cannulas to try to puncture the eyeball with a cannula, and you can't. You can't. It's really, and it's 25 gauge, 1.5 inch cannula. It's pretty strong. It's pretty tough. You can't do it. So that makes you feel a little better, but honestly, does it really matter if the patient's going blind? Like, you just do what you have to do. But anyway, it sort of gave them a little bit of a focus on something that was a little bit better. And then we showed them where to go, like from the lateral canthus to the mid-pupillary line. Halfway through, you make a little puncture wound with the introducer, whatever size needle you're using, a 25 or 18, whatever. Then you skirt right along the floor of the orbit, and it guides you right into the retrobulbar space. And we showed how far that distance was, and we showed how easy it is to reach it with a cannula. And then we started injecting the other eye with dye, with hyaluronidase that was dyed. And we injected it, and all of a sudden the eye just kind of bubbles forward. Again, these are cadavers, obviously. The eye starts bubbling forward, and you can sort of see the dye. And so, of course, we started massaging it. And, talking to Dr. Yolen, he said, you probably try to get 10 cc's back there, 3 cc aliquots. After every 3 cc's, the eye, pushes forward, and then you have to gently kind of massage it back. The hyaluronidase allows everything to move posteriorly. And so we did that, and it was, my thought about it was like, if you're ever in that situation, hopefully you'll never, ever be, and in part of our network training, we just don't let people do injections in those areas that have a high likelihood of blindness, right? Including temples, nose, nasolabial, this area here. I call it the triangle of death or danger. They made me change the name. Hello, Janelle NP. Thank you. You're welcome. My pleasure. Hopefully you guys are learning something. I'm having a lot of fun. I'm waving to everyone now because you guys are so nice to join. You're so great. So I thought to myself, at least if they've done it once or twice, even if it's in a cadaver, you have some sense. It's like if you've never done CPR and you're doing it on a dummy or whatever the Annie is called, whatever you call it, the model. At least you have some idea what to do, which is better than having no idea what to do, right? So at least if you've kind of gone through the motions of loading up the syringe and the needle or the cannula, finding the spot, traveling along the floor of the orbit, getting into that retrobulbar space and injecting, at least you have some idea, and the patient has some idea of regaining sight. I mean, that was my whole thought behind it. And it was actually, I thought quite successful. The students were quite focused and interested, because I think probably what's going through their mind is, oh my God, I hope this never happens to me. And I thought the same thing for them. I hope this never happens to anyone, but it will. I mean, let's just face it. It's a numbers game. Let's just, be honest about it. Hello, Tracy, cosmetic nurse. Thank you for joining. She's a regular. Good to see you guys again. Thank you for the wave. So that was my goal. And then when we actually dissected the eye out, we're holding the eye in our hands like this. It kind of put everything in perspective for us. We could see the optic nerve, we could see the vessels behind it, and it was really kind of cool. So I thought, we're going to do this from now on. And how many vials would you recommend? We did three vials. 10 cc's is what Dr. Yolen recommends. I mean, again, the only mistake you ever make with an occlusion, right, is giving too little. Right. I mean, as long as you're dissolving it, you're fine. Although I will kind of take that back. Hello, Tracy. I will take that back because I did talk about 2 cases last week that I found, I'm going to say humorous, but an occlusion is never humorous. When two separate cases where people got 19 vials of hyaluronidase, which means to me they have no understanding of what they're doing. They have no understanding about endpoints. We actually talked about capillary refill, and it's shocking to me that people who've been in the industry for a while and are doing injections for a while weren't even doing capillary refill correctly. So I said, okay, let's really break it down. How do you determine capillary refill? Because once you've established normal capillary refill, you're kind of done, right? You don't need to keep going, because if you keep injecting more and more and more, you're causing more trauma, you're adding more pressure to the area. Who knows what the hell you're doing? But you don't need to keep doing it if you've reached it. Like usually after one vial, and Heather we talked about this the other day, we've probably managed between 40 and 50 occlusions in the course of our brief history. And every single one of them has been treated successfully except for 2, which ended up with permanent problems because they were a very, very significant delayed diagnosis and treatment and undertreated. So now that we understand how to do it, we're good at it, and unfortunately we're good at it because we've done so much. But it's okay. It's okay. But if you don't understand that once you reach a normal capillary refill and the patient no longer has any subjective symptoms of hypoxia or anoxia or no blood flow to the area, then you're good. You're good. And then you take your finger, or you take a pen, or you take a scissor, whatever you have, and you put it on the spot where you've had the occlusion, and you hold it there with some force for 10 seconds. So you're trying to drive out all the blood, and then when you let go, you count. See, that was pretty fast. 1001, 1002. If it's done, you're good. If it's more than 2, then you got some more work left to do. If it's 3 or 4 or 5, you probably haven't done enough at all. So you have some idea, but the minute it gets back to what's considered normal, you let the body take care of itself, right? Because if you had an occlusion, you got all those free radicals being liberated, you got all those terrible things happening, you got vascular congestion, and it's kind of growing, and then you go and dissolve it. It doesn't turn better in a second. It takes time. So give the body some credit, give it some time to work. But anyway, hello, that's Glow Girls Beauty. Good to see you guys. And another wave to you. Thanks for joining. But I wasn't really planning to talk about that, but I just found it so fascinating, and I think, as I talk about things and discover things, I include them in the cadaver course, and it was just so much fun. And you could just see when we were showing people the anatomy, and we let them inject the cadaver heads, and then we cut them open, and they could sort of see where they injected. And most people were really quite surprised at how close they were to disaster. Thoughts on the ultrasound to help with identifying occlusions. Necessary? I don't know. I mean, it's kind of like a technology searching for an application. I think, I don't know. I don't know how to read those kind of ultrasounds. Do you? Do you want to get trained in reading those ultrasounds? I don't. Do all of our occlusions been treated successfully when they've gotten treated in time? Yes. Do I need an ultrasound to show me where the occlusion is? No. Do I need an ultrasound to show me when I've got normal capillary refill? No. Don't forget, you're not trying to get into the vessel where the occlusion is. You're trying to bathe the entire area and dissolve all the HA everywhere. You're basically opening up all the doors and windows when you've got a fire, right? You're letting all the stuff out, you're letting all the fresh air in, you're kind of just blowing everything out. So I don't need an ultrasound to tell me the fire's in the kitchen on the next to the stove. I don't really care, right? So I'm not a fan. I don't really care about it. If you want to do it, buy it, pay for it, knock yourself out. But the time you waste trying to find the ultrasound, I don't know that it would change anything I do. Because then you've got to have another person holding it, another person doing this. I don't know. I believe in doing what I know works, and I know what works for me, and I know it works for all the ones we've done. So I'm going to come down on I don't see the necessity for it. I don't see that it's going to really change anything I do. And if you understand what's happening beneath the skin, I don't know that the ultrasound is going to change anything. But you know what? If you want to try it and play with it and see if it makes sense for you, go ahead. But I'm not going to waste my time and money. Thank you. The best thing to do is never have an occlusion, then you don't really have to worry about the ultrasound. But that's neither here nor there. So the other thing I want to talk about, I mentioned Amy Burke was supposed to be on with us tonight. Her daughter unfortunately had a concussion, and so she's unable to join us tonight. But she will join us on the 26th, I believe, which is 2 weeks from tonight. And we're going to have Marjorie Preddy, who's one of our nurses. She's amazing. She will be with us in an unprecedented Thursday evening version of Ask the Mentor. So stay tuned. She's amazing. She came through our school, and she's going to tell you her story, which is great. Which occlusions are most frequent, venous or arterial? Well, the arterial ones are dramatic and hard to miss, right? They're very obvious, and it's immediate. It's blanching the patient. I will talk about Bellafill. Thank you for bringing me back to what I was supposed to talk about tonight. I've gotten off on this rant tonight. I'm just filled with passion tonight about this. I was so revved up on this cadaver class. But yeah, venous and arterial. So arterial, occlusions are immediate. The area turns white. You turn white. You fall over. You're out of your chair. The patient's complaining of pain. You see it in the distribution of the artery, and you have to act. There's no question about it. Venous is different. Like, you could treat someone and think everything looks good, and we've seen this before. The patient goes home, you go home, you start drinking wine and whatever you're doing, and the patient calls 2 or 3 hours later and says, one side of my face, feels different than the other side. This side feels good. I don't know, this side feels a little hard, and the color's a little different, and send me a picture, text me a photograph, put your wine down, make believe you didn't drink it, and then look, and you sometimes see that, yes, this side looks like it's getting some venous congestion, and yes, it's getting more painful, and yes, I need to see you right away. Don't wait on those. We've actually had one case from someone in our network who had a venous congestion 2 days later. So they probably had a partial occlusion, and then over the course of 2 days, maybe the product took on some water. Who knows what happened? Maybe they massaged it, it went distally, and they had an occlusion. Again, it was treated well. I think the arterial are more obvious, so those are more commonly seen. I think the venous are, maybe some people have them and they just think it's a bruise and they don't really treat it. Maybe they're undertreated, but I think the venous are sort of like underwhelming and unexciting, so maybe they're underdiagnosed and undertreated, but the arterial are more common only because they're so obvious and we see them right away and everyone pushes the panic button. So, hello Deluxe Bar, you're definitely getting away from me. Thank you for joining. They are the best. The Deluxe Bar. And the Deluxe Bar has been an inspiration for us, talking about occlusions, because they help me a lot with the ones we get for the network. We haven't had one in a while, and hopefully every time we have a problem, we try to figure out a way to solve it, and whether it's a change in technique or people just not being able to treat that area or using a different product or whatever it is, we've addressed it to sort of minimize our level of occlusions. And I would say by far the most common side of occlusions, can anyone guess? What's the most common side of occlusions pretty much anywhere? It's the lips. Anatomy's different, anatomy's harder, less forgiving, and it's one of the most commonly requested areas. But I'm going to get back to Bellafill because people are asking me, what about the Bellafill? You said you were going to talk about it. Okay. All right, Anna's getting away. All right, so what is Bellafill? Pedro said to me, what is Bellafill? He'd heard of it but didn't know what it was. And I said, it's a filler. So what's so special about it? I said, well, it's really different because it's permanent. And he's like, he wasn't sure if that was good or bad, because initially that was the holy grail. Like, people were getting filler fatigue. Remember, I go back 30 years now. So when we were looking at fillers, they were lasting, we had collagen from a cow that lasted, we said 3 months, but it was like 3 or 4 weeks probably. And we were looking for longer lasting products. And then people said, well, the longer lasting, the better. The more you can charge, the longer it lasts, the more areas you can treat. So it was a good idea. Whit Boss is there. Cool. But sometimes you don't want a product that lasts a long, long time. Can anyone think of a situation where you might not want a product that lasts a long, long time? Like maybe an occlusion? Or maybe a bad outcome for a patient, or maybe an overfill, or maybe all the reasons that we dissolve products. If you have a product that's permanent, you can't. So let me just explain what it is first, and then we can talk about it. And someone also wants to know about the nodules that are associated with it. So I call fillers like Bellafill, like Radiesse, Sculptra, Bellafill, Artefill, Articol, the old names, biostimulators. Because yes, I mean, in my opinion, a filler like any of the Radiesse, or any of the Juvederm family or Restylane family, those are all fillers. You put them in. They're HA products, you put them in, they take up space, and you're done. They slowly break down, and that's the end of it. There's nothing exciting about it. It's a filler, it takes up space, and you're done. But these biostimulators, like for example, Sculptra, which is a naked biostimulator, you inject it, it creates an inflammatory reaction. There's these polylactic acid particles are, inflammatory, and inflammation creates collagen production, and collagen production is what we want to make our skin thicker and tighter and all that sort of stuff. So that's great. However, they're sort of fillers that are both, like Radiesse and Bellafill in my mind are kind of both, because I call them fluoride toothpaste. So it's like you've got this paste, which is white, whatever, and you've got particles of calcium, like for calcium hydroxylapatite, which is Radiesse, or fluoride toothpaste where they're fluoride, or Bellafill, which are PMMA, polymethyl methacrylate, and I'll explain what that is in a minute. Maybe it's not a good idea to have a permanent filler. Sometimes it is. But sometimes it's not, and I'll go into that in a second. I'll tell you when I use it and why I use it. So when you inject these fillers like Radiesse and Bellafill, 70 or 80% of it is just this carrier, like the paste itself, and that dissolves in 8, 10, 12 weeks, it's gone. And these particles of calcium, fluoride if you're using fluoride toothpaste, or PMMA, polymethyl methacrylate if you're using Bellafill, are liberated, right? The body now has access to them. The macrophages, the neutrophils attack them. What are these particles doing here? This inflammatory reaction goes on, and that creates this collagen, right? It happens in everybody. The older you are, the sicker you are, the less well you are, the less you make, but it still works in everybody. Obviously, it works best in the people who need it the least, who are the younger, healthy people who don't need much. But Queen Botox, where have you been? Thank you for joining, Queen Botox. Where are you calling from, Queenie? Or watching from, I guess is better. You're not really calling me, even though we're using a phone. Interesting concept. So when you're injecting Bellafill, which used to be called Articol, then Artefill, now Bellafill, its carrier, if you will, is collagen. Not human collagen, but bovine collagen from a cow. So you say, well, wait a minute, you talked about that 30 years ago and it wasn't very good. Well, it wasn't very good because it's still antigenic. Your body still recognizes it's from a cow. So it still goes after it and breaks it down. And we had to be allergy tested all the time to be sure that the patient wasn't going to react. And even sometimes after getting it 6 or 7 times, on the 8th time they reacted and had a terrible thing happen. So it wasn't great. But they kept modifying the collagen to make it less antigenic. And now they say it really isn't, and you don't really have to be tested against it, but we still kind of do. To be sure, because you can never be too sure. And then once that dissolves, these PMMA particles are released. And I looked up, I just Googled to see what is PMMA called in real life, and it said PMA is called acrylic glass, and plexiglass. That's what these particles are made of, like little pieces of plexiglass. How well do you think your body breaks down plexiglass? I mean, you can't even put it in a dump or any place on earth because it can't break down. Even if you bury it, how well do you think your body is trying to dissolve it? It doesn't. So that's why it's a permanent product. It can never be, that inflammatory reaction never stops. And I was at an office, a number of years ago, where this one doctor, and I went to learn about Bellafill from this doctor who did a lot of it. And many of the patients came in and they had like a moon face, like this. And I was like, what do you think's going on there? Well, the thing is, like once you inject it, it never stops. You can't stop it. So how do you inject it? How do you know? How do you under-inject it so that you get a happy patient, but not over-inject it so that 5 years later when they come back, they look like they put on 150 pounds? I don't know the answer to that. I don't know if there is an answer to that. But I had dinner with the head scientist at Suniva, who with the company that makes Bellafill. And he's like, yeah, it's permanent. We're never going to say it. The studies they did went out 5 years, and it was still there in a big way at 5 years. So it's a permanent product. So we generally don't allow people to use it because God forbid you should have an occlusion. God forbid you should have an unhappy patient or a bad result. God forbid you should overcorrect somebody. You can't take it away, right? So you're like, well, Russo, why the hell are you using it? Maybe I'm just stupid. I don't know. But sometimes I talk to you out of it. I'm not trying to talk anyone out of it. I'm just being honest. I mean, why would you want to use it? So here's when I use it. I've got patients that come in, and they've been, again, this is my 30th year, so, I've been through this a million times. There is such a thing as filler fatigue. Patients come in, and how many times can they come in, and how much can they pay over the course of a year or two for filler? Like, it's expensive. You can only correct, how many syringes of Voluma that you charge $1,000 or whatever dollars for can you put into a patient in a given year, knowing that it's still going to break down, right? So sometimes patients are just fed up with it. They're like, can you just do something that's longer? I'm tired of coming in. I mean, I like seeing you. You're a great person, whatever, but come on, really. Spending enough money to buy a second home here. So I can do fat injections. Mel, oh my God, we're just thinking about you. We just did another cadaver class, and I saw a video of you in the old cadaver class. She's going to be a rising star. Keep your eyes on Mel. Mel is awesome. Thanks for joining. I was just talking about how we did retrobulbar injections, not in your class, but the class after, on Monday. And I'm sorry you missed it. You'll have to come back to another cadaver class. But anyway, so I forgot what I was saying exactly, but Mel has completely distracted me. But so when you inject it in patients, they get filler fatigue, and they're just like, okay, enough. I inject it in patients that I have done a lot of filler on, that are very filler savvy. And I'm still a little nervous when I do it, but I don't go anywhere near areas where I know you can get an occlusion. I'll do the jawline, I'll do the angle of the mandible, I'll do these areas in men. If I do it, I'm always doing it. I'm never bolusing. I'm always doing it, tangentially. So I'm very careful with it. And because of what I told you, the fact that it never stops going, that inflammatory reaction never stops, I don't try to get anywhere near 100% correction. When I went out to watch this other doctor inject, and he was injecting at least a full box of it on every single patient, and they would ask the patients what their budget was for the day, and they would only inject patients that could buy at least 5 syringes. If they didn't do at least 5, they were just like, we don't have time for you today. I'm sorry, And so I went out to dinner with a bunch of these people who used a lot of Bellafill, and I was sitting next to another doctor, and she was looking at me. She goes, "Oh, have you ever had Bellafill?" I'm like, "No." She goes, "If you come in, I'll inject you." I was like, "Oh, yeah, really? Yeah. What would you do?" She goes, "I would inject about 34, 35 syringes in your face." I was like, "What?" She goes, "Yeah, just inject all the areas, about 35 syringes." I was like, "Really? All at one time?" She goes, "Oh yeah, just get it all done, half hour, 40 minutes. Yeah, it's all good." I was like, but it doesn't stop. It keeps going. What if my face is too big? What if you put too much? And she's like, "Oh no, I've done a lot. I know what to do." I was like, "I don't think so. I think I'm going to fly back to Boston, and I'm just going to forget about that." And so I never did. But I just found it very interesting that I think she was the number one Bellafill injector in the country. She had done more than anybody. And she was just doing it all the time, all day, and just taking no prisoners. So I'm not kidding. I swear, Janelle, I'm not kidding. I'm being 100% honest. I never kid about this kind. Well, I do kid, but I seriously kid. But no, so it's kind of scared me. So I stayed away from it a while. So I still have some in the fridge. I still use it occasionally. Sometimes I'll use it in people who have depressions in their leg, or they've had steroid injections, or people took too much fat out of an area, and I've got this dimple, or I'll put it there because I'm not worried about an occlusion. I know it's going to keep going. It's going to build on itself. So I think it's a product that's useful, but I would never use it on as a beginner injector. I would never use it. First of all, I would never use it unless you're really, really good at injecting and you've gotten a lot of experience. And then when you feel like you're on top of the world and you own it, then you'll come falling down, because if you do it and get an occlusion, you'll say, "Oh my God, I should have never done that." But as I said, I'm still nervous about it when I do it, but I'm managing to do it. And these are for patients that I know really well. In fact, most of them are friends. I've done it on my wife, things like that. So anyway, someone said, "What about the nodules you get with Bellafill?" Well, I've seen it a few times. I don't know. People are hyperactive, hyperacute, and the problem is, if you do get a reaction to the polymethyl methacrylate, guess what happens? You're SOL. You're shit out of luck. I guess you could go in there and cut it out. I've done that with silicone. I've cut silicone out of people who've gotten silicone injections in their lips or their face. That's another product that it's a gift that keeps on giving. It never goes away. It becomes integrated into the tissues. It creates this whole area of scar tissue. I mean, it's the most miserable, horrible situation to try to get out. I've seen people who've been like from Vietnam or Southeast Asia, and they've had their breasts injected with silicone. They have to have mastectomies. I mean, it's a terrible thing. So, I mean, the point I'm making here is that just to raise the level of awareness, because a lot of people just don't understand. 5-footer join. A name like that deserves a wave. Don't you think a name like 5-footer deserves a wave? I'm proud of you for trying this. So that's the deal. Just know what you're dealing with. Know you always have to have a plan B. Come to the cadaver class where we show you some retrobulbar injections in case you ever get blinded. But by practicing this, you know it'll never happen to you. If you never practice it, you know it may happen to you. So just a word to the wise. Any other questions before I sign off? Because my mouth is getting really dry. I feel like I've been talking and talking and talking. Hopefully that's been helpful. So Nurse Preddy, Marjorie Preddy, is going to join us Thursday. And unprecedented, especially for her Thursday evening at 7 on Ask the Mentor. And then Amy Burks, RN, who's a founder of Glowderma, who's like everywhere, a million places, doing great work. We're going to talk about raising the level of education in aesthetics. Like, this is what I'm trying to do. This is what she's trying to do. We'll talk to Nurse Preddy about it and ask her what she's trying to do. I'm coming. You're awesome. Thank you. So are you. I can't wait to see you. How often do you come on live? I think it's every Tuesday at 7 for the last year. Pedro was just saying he's recorded 35 hours of me talking like this. He's like, I don't know if I can take any more. But we're here every Tuesday for you.
And
every
Thursday.
And what?
Next
and Thursday. This Thursday.
Yeah.
This Thursday. So be there, be square. You're welcome. Thank you for thanking me. When is the next class? We do it 8 times a year. So, twice a quarter. So probably, every month or two we're doing it. So, oh, Mel, sorry you came late, but you can watch it. We're gonna post it right away. We're gonna post it right away because we just did it on my phone, so you can hear all the stuff. But we were talking about you this week. I was talking about what a great student you were and how I expect you to be living this stuff shortly, and quitting your day job. So that's all I got to say. It's been a lot of fun. You got it out of me tonight. Bellafill, cadaver injections, retrobulbar injections, learning how to be careful and safe. So I'll see you guys Thursday. If you can't make Thursday, I'll see you Tuesday. Ask the Mentor. Have a great week, everybody. See you then.